Hello, everyone. It's 2 past the hour, so let's get started. Thank you so much for joining this APMENxChange webinar. My name's Lorina McAdam. I'm a consultant and friend of APMEN and CSOs implementing malaria programming. I'm sure you know, but just to confirm that this webinar's topic is new challenges, existing networks, civil society experiences from the Greater Mekong sub-region during the COVID-19 pandemic. So we'll be looking at the role of civil society in malaria control and elimination, some of the challenges that have been faced during the current pandemic, and some of the responses that have been developed. And we hope to look forward ahead also to see what we can learn from this current situation to taking things forward with malaria elimination and health. The Senior Director of APMEN, Amita Chebi. Over to you, Amita.
Thanks a lot, Lorena. Welcome, everybody. I'm delighted to welcome you to the second edition of the APMENxChange. APMENxChange is a platform that was really created to facilitate the sharing of information between APMEN partners from implementation experiences from the ground, and we focus attention on the critical challenges that are happening through the journey of malaria elimination. So our first APMENxChange webinar focused on the issue of the pandemic and guidance by the world issue, but through the lens of civil society organizations in the greater region. We have several questions. Most of you know to her support of this webinar.
Thanks, Amita. I'm afraid it seems that we're having some issues with the sound. I'm not sure how much of that people caught. I couldn't understand much myself. I don't know if others can hear me, but I suggest that we push on, and we can always share some of these comments afterwards as well to make sure that no one misses anything. Great, thanks for confirming that you can hear me okay. So I'd just like to run over, well, first of all, again, welcome. I see that we have 77 participants at the moment. We have participants who've registered from 29 countries. So thank you so much for joining us from all over the world, particularly if this is an awkward time for you to be joining us. I'll run through the mechanics of today's meeting. You'll notice that your audio and visual is disabled, but please do share comments with us in the chat box. We have 4 presentations today. Each person will be presenting for 10 minutes each, and we're going to run through all presentations before moving to a question and answer session, and we'll leave lots of time for that. For the Q&A, what we suggest is that you'll see at the bottom of your screen, there is a Q&A box. Before you ask a question, what you might like to do is see what questions have already been asked. And if you see one that is similar to yours or one that you're interested in, please upvote it, because the questions with the most upvotes are more likely to be asked during this webinar. If you know who you would like to direct your question to, please feel free to name your speaker. And also just to note that we are recording this webinar, and after the meeting we will be sending out the recording, the presentation, and we're also hoping that our speakers will be able to respond directly to any questions that we don't get to just to get some feedback so we can gauge how useful this was to you and how we can continue improving this webinar series. So I would like to introduce our speakers. As I mentioned, we have our 4 speakers. Our first speaker today is Shreehari Acharya. Shri is the project manager for the CSO platform in the Greater Mekong subregion. He works for American Refugee Committee, and he has over 10 years experience as a public health professional. He's been involved in developing and implementing national strategic plans and facilitating the involvement of communities and civil society. Shri is a very passionate advocate around community system strengthening and health equity. And our second speaker is also a very passionate advocate. We don't have time to go into all his achievements, but one of those was initiating the CSO platform here in the GMS. Mr. Louis Da Gama is also the humanitarian advisor for Yvonne Chaka Chaka and the director of her Princess of Africa Foundation, as well as his own foundation, Blessed to Give. Louis is an ambassador and board member with many important institutions such as the RBM Partnership to roll back malaria, or to end malaria, UNICEF, UNITAID, Global Fund, and he is currently serving his 2nd term as the community and civil society representative for the Global Fund Regional Steering Committee in the Mekong. Our 3rd speaker today is Dr. Hnin Su Su Khin, also known to us as Masu. Masu is a medical doctor and holds a Master in Public Health. She has over 20 years of experience, and I had the pleasure of working with her in PSI, where she was leading a flagship program on artemisinin monotherapy replacement. And Masu is currently the operations director at Medical Action Myanmar. She oversees 50 mobile medical teams and around 2,000 village health workers. So it'll be great to hear about her experience there shortly. And our final speaker is Dr. Eisa Hamid. Eisa is the Regional Senior Program M&E and Health Systems Specialist working with the Principal Recipient UNOPS for Global Fund in Asia. Eisa is an epidemiologist and public health physician. He's held various technical, advisory, managerial roles with NGOs, the UN, and the public sector. He's been working in Asia since 2012 with UNOPS based in Yangon. So you can see we have a great selection of speakers with us today who will all be bringing different perspectives to our main topic. So to kick things off, I'd like to invite Shri for our first presentation today on challenges facing civil society organizations implementing in communities during COVID-19. Over to you, Shri. Thank you.
Thank you so much, Lorina, for a very nice introduction. And I would like to start thanking Admin Secretariat, especially Amita, for organizing this webinar and allow us to share the experiences. As Lorina said, I'm working with the Malaria CSO Platform covering Greater Mekong sub-region. The platform is civil society constituency for the Global Fund RAI grant, and it works cover basically advocacy, communication, and capacity strengthening of the civil society and communities in the Greater Mekong sub-region. So I would start with a little bit of background on the CSO. In the GMS region, unique role of CSO is to their ability to expand service in a remote and hard to reach area where the health system is still not able to reach, and their trusted relation with the local community, particularly with illegal mobile and migrant population and population who lives in the rural area, especially ethnic community and the people living in the conflict area. And also they work, civil society, they work with the community and they use the local context and local language serving the populations. So because of this unique added value or identity, civil society in the region are able to gain the trust from the community and implement the services. Under the RAI 2E grant, there are more than 50 civil society organizations implementing malaria project in the GMS, and more than 33,000 volunteers are working in their projects. And I will just go through some of the number in Myanmar. If we see the implementation of the civil society, 40% of malaria tests were contributed from the civil society organization, with 60% positive cases were found from them. In Laos, 13% tests were done by the CSO and 20% positive were found from their tests. So this is the overall picture. So now I'm going to give you some of the scenario since this COVID has started in the region, even though this region doesn't have a very big problem of this COVID, but this challenge was all around since it started. The challenges I'm sharing is based on our consultation with CSOs in the region and shared information from them. And if you follow the Louis' presentation, I will highlight the challenges, and Louis will be presenting how we are addressing those challenges and keep moving the malaria program. So since the beginning of this COVID, there were a lot of travel restrictions and physical distancing affected activities implementation in the community. Malaria worker and volunteer has lack of information about the COVID when it started. People were in a situation that what to do and then how to respond to the situation, not just malaria, but the COVID. There was very limited protective gear for frontline worker, for example, face masks and sanitizer. And most of the health facilities were focused in COVID response, so they had their time to focus malaria project was reduced. So that was the very high level challenges. So if you go deep down to other challenges, since beginning until now, volunteers are expressing fear and anxiety to provide services, especially to fever case, because COVID also comes with fever and malaria. So this challenge still remains. Community gathering and conducting awareness session, screening, monitoring, and the evaluation activities are no longer possible, even though it's now COVID situation is slowly improving, but these activities are still not possible to implement as we were able to do before. Activities implementation on the border is challenging due to border closure, and communities in those relying on the border malaria services are at risk. And in this region, mobile and migrant population are among the high-risk population. Airline mass distribution campaign are no longer possible, so CSO need to change their strategies, and they are changing that in a door-to-door distribution. Number of tests and malaria positive case has decreased in April and May. We are trying to gather the information or what was the actually effect in terms of achieving those numbers. So probably we will be able to share sometime in July when we get the clear picture. Stakeholders coordination was affected and so many activities were put on hold and delayed. Monitoring and data collection activities were also affected by the COVID. Monthly meeting of the volunteer have been impacted volunteer or village malaria worker, they face challenges to submit report timely due to the travel restriction. And travel for the central staff for the MNE and training is no longer possible, which affect the routine malaria surveillance activities. The CSO staff, they were no longer able to support the data recording in the system as usual to the government officers and the health facilities. So in terms of commodity, there were no malaria commodity issue reported by the CSOs, but they were watching and monitoring the situation just in case it is happening. But there was issue of procurement of the PPE, face masks, and hand sanitizer due to the high demand, and some countries were heavily depending on the import. So that's the overall challenge. And as I said, we are regularly following up with the civil society organization, and we will be updating in a monthly basis. So I would encourage you to follow our website and our Facebook page, where we will be updating situation regularly. Thank you so much. Over to you, Lorina.
Great, thank you so much, Shree. That was a really helpful overview, and firstly, a good reminder about how many civil society organizations are contributing to malaria elimination strategies in the region. When I first saw Shree's presentation, I was concerned because it paints such a bleak picture about the challenges that we're facing in response to the government restrictions in place to prevent further COVID transmission, to obviously everyone's attention has been diverted to the fear that a lot of the communities are facing, which is no doubt compounded by the lack of access to PPE. So clearly a lot of challenges that are disrupting the usual activities. So I'd be very happy to hear from Louis, who will be talking about CSO's contribution to national malaria control and elimination programs in the time of COVID, to give us an idea about how civil society have been responding to these challenges. So over to you, Louis.
Good morning. Can you hear me, Lorina?
Loud and clear, Louis, go ahead.
Okay. So thank you to APMEN for the collaboration with the platform. It has been a difficult time for many CSOs, and one of the good things about the platform is that we've been having regular calls with the various CSOs in the countries, trying to understand how they are dealing with COVID, what their critical problems are, and how they're trying to find solutions to that. But before I go into the details, I just want to make a couple of points around civil society generally. And that is that we talk about civil society like we are a homogeneous group of organizations, and we're not. There's a huge plethora and diversity of organizations, from large international NGOs to very small community-based organizations, perhaps working in one country, regional organizations working in all 5 countries, some organizations that are faith-based, or civil society organizations that are focused merely on service delivery, while others are also involved in advocacy for policy change, for resource mobilization, and for working effectively on transparency and accountability of processes for the Global Fund and beyond. So we need to understand that civil society is not just a single group of organizations. Having said that, the 50 or so organizations that Shree referred to are mainly working and focused on service delivery, extending their support to the government in terms of being able to deliver essential malaria elimination services to remote and difficult and hard to reach communities. And during this time of COVID, the organizations, the civil society organizations, have worked very closely with the government to support their COVID-related guidelines and regulations, making sure that remote communities are aware of what's going on and what's needed. And this is particularly important during this time where the fear and concern has been growing. The unique thing that these organizations have is a close relationship with their communities, and therefore delivering messages by local radio in local languages, using loudspeakers and posters in the community have helped, because obviously with the difficulty due to travel restrictions and social distancing, face-to-face meetings have become much more difficult. They've also been engaged in dealing with the severe problem in the early stages, where there was very little PPE, and many community health workers were concerned because they did not have access to face masks or hand sanitizers. And so the civil society organizations have been using Global Fund resources through procurement with the government, but also have been able to advocate for their own resources. And some of the big INGOs have been able to get their own resources to provide PPE to community health workers and malaria mobile workers too. In Myanmar, there's a unique situation where besides the public health system, there is a very strong and vibrant private provider system where not only doctors but also pharmacies have been providing services for malaria elimination, including diagnosis and treatment. And during this time of COVID, they've been helping with providing screening for their communities, as well as making a particular focus on psychological counseling, helping people who may be stressed about COVID and their ability to catch it. And so psychological counseling has become increasingly important. Next slide, right. So, Shreehari already said that in RAI RSC, the main mechanism for getting long-lasting insecticide-treated nets out was based on mass distribution. And obviously this is no longer possible. And so they have been moving to door-to-door. And I want to encourage, real focus here, because we could learn a lot from the door-to-door campaigns that were run by HIV, trying to ensure that they were using the opportunity to have messages around HIV to communities via door-to-door and door-to-door testing. And I think the same is possible with long-lasting net delivery. I think the critical thing, though, is how we use these door-to-door distribution mechanisms to increase integration with the other disease areas, to increase service delivery. So it's not only providing long-lasting nets, but how can we collaborate to maybe with the HIV community to do HIV testing? How can we perhaps use the mass vaccine testing campaigns, which have also moved door to door, so that we are being more efficient and more effective? As I said, there is obviously concern and fear in the community, and the need for empowering our community health workers and our mobile malaria workers to keep testing and keep treating where that's possible, and then keep referring where that is the primary way of dealing with malaria. And this has required much more intense interaction between CSO workers and the community health workers and mobile malaria workers, and really the need for supporting them, for mentoring them, and for ensuring that they're encouraging them and trying to understand their concerns and helping to alleviate those concerns. But obviously this work is critical and can only really be done providing there's a huge amount of trust between the CSO and the community that they're serving. And the CSO is actually using their mechanisms and their connections to break down social, cultural, and language barriers, so that government messages are actually reaching the community in a way that the community can understand and use and feel protected. Obviously, like everything else, as we are doing here with virtual communication, that has been incredibly important. But I think virtual communication only works with communities where there's already a system of trust. And a particular example that we have in Laos is that the CSO platform over the last 2 years has been working to develop a networking mechanism using mobile phones to connect community health workers and mobile malaria workers together in a single network, so they're able to communicate with each other. And I think this is a great opportunity for them to be able to do a little bit more self-help and share their experiences with other community health workers and mobile malaria workers, not only in their own particular geography, but more widely, and therefore feel supported and understand that some of the concerns that they are having and feeling are also shared by others, and they're not alone in this fight. Next slide, thanks. So Shreehari already pointed out that there have been concerns and difficulties with monitoring and data collection, because we can no longer do that face-to-face, and that CSOs who are often based in the capital city need to travel out to the remote areas to be able to look at what's going on at the community level. And that's obviously, due to the travel restrictions, not possible. And so in Thailand, in Myanmar, they have been using increasingly social media and apps on their phone to be able to collect data, to be able to report data, and to be able to share with community health workers and mobile malaria workers some of the information that is required, and an interaction between the two has been very helpful. In Laos and in Cambodia, they have continued with paper-based reporting systems at health centers, but they no longer gather together as a single group, bringing together several or many of the community health workers and mobile malaria workers in that particular vicinity close to that health center. They're having to do that very much on a one-to-one basis, and then work with the health center remotely. And in Vietnam, the CSOs have been using their CMATs, their community malaria action team members, to be able to go to the commune health centers through their referral system. Next slide. Similarly, for surveillance and data quality, CSOs have been using their mobile phones and social media to connect with community health workers and mobile malaria workers to provide technical help and guidance. It obviously is difficult trying to do that virtually, but if you have a system of trust and you have a relationship between the CSO staff, because they've been doing this regularly since RAI began in 2014, it has been relatively straightforward. And obviously, when they seek problems, they're able to talk about ways of improving data quality. Next slide. As Sri said, there haven't been many reported problems related to malaria commodities. But there have been concerns specifically initially around having access to PPE. And so getting masks and hand sanitizer and other PPE requirements to remote communities with the travel restrictions was difficult initially. Those problems have been overcome. And then specifically in Cambodia, because of the way the Cambodian system has been set up with the CSOs providing really hands-on help at health centers, at provincial PhDs and ODs, there have been an opportunity to work much more closely with the government programs at subnational level on monitoring all sorts of things, but including stocks and supply chain. And I think that's my final slide. I think that's basically the way civil society overall has been working and helping governments reach communities that have been hard to reach, particularly indigenous populations, ethnic minorities, mobile and migrant populations, and internally displaced populations as well, and refugees. With that, I'll turn it back to Lorina.
Great, thanks so much, Louis. That was a really rich presentation. And I have to say, you're looking particularly wise with your beard these days. I'm loving this new COVID look for you. I mean, there's a lot there. I really appreciate the fact that you raised the diversity of civil society. Obviously, there are so many different strengths that we can draw on there, depending on the different agencies involved. And it was really inspiring to hear that how much adaptation has been possible. I was really excited to hear that there is some support for the psychosocial aspect, particularly when there is so much uncertainty and in the world right now. I think that is so important. I was glad to hear that these door-to-door approaches really create some opportunities for us, and not just for net campaigns, but for other activities. The use of technology and how that's been leveraged to provide support and to ensure surveillance keeps taking place. But I think what I took away most of all was the importance of trust, trust that civil society has with their communities, and also how this has been able to work so well in terms of engaging the local authorities, the national program, to both reinforce messaging as well as to figure out how to address some of these issues at the local level. So thank you, Louis. And so to follow on from that, I'd like to hand over to Dr. Ma Su to talk to us more from an implementation perspective specific to Myanmar. Her topic is, maintaining malaria services amid COVID-19 in Myanmar, a CSO perspective. So over to you, Ma Su.
Okay, thank you, Lorina. Can you hear me?
Loud and clear.
Okay.
Lovely to see you.
Thank you. Yeah, nice to see you too. Let me change to the. Okay. Yeah. Okay. Thank you, Lorina, and all the APMEN network for organizing this, and also good afternoon to everyone who's joining today's webinar, and thank you for giving me this opportunity. So I would like to, as Lorina has introduced, I would like to, share some of the experience from the implementation perspective, as we are the frontline workers working in the field. So yeah, so before going to the experience, and then let me start with the malaria pattern in Myanmar. Like in Myanmar bears the highest pattern among all the GMS countries. Out of 330 townships and 291 are considered as malaria endemic, with 44 million at risk. So, however, malaria has declined significantly, over the past decade due to the support and effort of all the donors and partners. Nonetheless, we still have found more than 47,000 confirmed cases in 2019. And however, the malaria become, quite a concentrated focus. It's not like it's not heterogeneous. It's not everywhere. It's becoming concentrated in some areas than others. So 10 townships contribute 70% of the burden in Myanmar. So if we look at the total cases, 25% came from Palawa, which is the red one, in this map that shows the API map on the right side, which is the North Indian Myanmar border, and also 16% from Papon, which is in the eastern border, like between Myanmar and Thailand. And so because the malaria is now more concentrated among the forest workers who are living in the forest, and like the seasonal farmers and mobile migrants. So those areas are more where the public health services are scarce. So malaria volunteers are the frontline workers providing malaria services in Myanmar. So in Myanmar, there are more than 22,000 malaria volunteers deployed by the National Malaria Control Program of MOHS, Ministry of Health Services, and also by the CSO. So you will see below 3 pie chart that shows that the number of volunteers distribution of number. The first chart shows the number of volunteers managed by, deployed by the CSO, and which is 32%, and the rest is managed by the National Malaria Control Program of Myanmar. And then the second pie chart shows the number of patients tested with RED, where 53% was contributed by CSO, and the last pie chart shows the number of patients detected and treated by the volunteer. So 71% came from the CSO, which clearly shows that CSO volunteers reach more higher risk people, which is like more remote. They are in a more remote area and they reach more to the mobile and illegal people. And that is like, this shows the role of malaria volunteers is very important in malaria elimination in Myanmar. And because like for those who don't know who Medical Action Myanmar, I want to explain a little bit on who we are and what we do. So we are a local NGO founded in 2009 in Myanmar, and we provide health services to the poor and vulnerable population in Myanmar through two like service delivery model. One is through clinics and the other is through volunteers. So on the map on the right side shows where we are. So that red dots are the clinics. So we have 10 clinics. They are mostly in the urban area, targeting to the slum, peri-urban, slum poor community. In 5 in Yangon and like 3 in Kachin and 2 in Cayenne. And then the yellow dots represents the malaria volunteer. So if you look at, as you can see in the map, we are mostly in the border area and very remote, far and ethnic area. So we are in the northern India Myanmar border in Kachin, and also in the Palawa in the Rakhine in Chin State, and also in the Myanmar Thailand border on the southern part. So we have about 2,000 volunteers in our network. So what we do? So malaria volunteers provide malaria services, which means they do RD testing, they provide treatment according to national guideline, and they also do align distribution, both in participate in the mass distribution campaign as well as in a continuous distribution, targeting mobile migrant and high-risk people who missed during the mass campaign. And they also do health education and behavior change communication, and they report to the national program, and also they are part of the surveillance system for malaria elimination area. In addition to malaria, they also provide other integrated health services. So they do health education in the community and look for the people who have the symptoms suspect of TB, and then they refer to the national TB program. And when they were diagnosed as TB and provided treatment, they do TOTS, like directly observed treatment. And they also do contact tracing and things like that. And they also provide basic health care for the most common minor illnesses such as diarrhea, pneumonia, and also they also do an emergency referral. So this is what we do in the community. And MEM provide training and support and supervision and supplying of the commodities to them. So for the COVID, as Shreehari and Louis has explained in their presentation, in the previous presentation, I mean, despite Myanmar still has quite low number of COVID confirmed cases. I mean, up to now, we have only 261 cases. One might argue that because of the low testing, but despite that, these cases are associated with those who return from outside the country. So local transmission is very non-existent, or maybe, very few local transmission. So despite the low local transmission and low number of cases, that the panic is in proportionate, very big. So, and in response, the public panic, and also in response to the COVID transmission, the governments, there are restrictions from the government on the travel and also lockdown, and also there's an extreme, for information oversharing, previous on the past decade, there's very little information. Now is information oversharing on the social media, and many of the information are incorrect. So it leads to the panic to the public. So what happens is in some of the community, they are panic self-isolation. What I mean by that is when the government official announcement is only lockdown, a quarantine only for those who come back from the outside the country. But in some community, everyone who are stranger, who come back from anywhere, were put into the quarantine, something like that. So no one is allowed to to visit or to stay in their house or in the villages. So there's a kind of isolation. And that limits our regular supervision monitoring activities. And also, of course, it also disrupts the supply chain system, and restrictions on the mass gathering also affect our community activity, like airline distribution, health education, and and things like that. And also, of course, the training are also must affect the delay. And then because of the panic to the fear to the COVID, people are reluctant to visit clinics, because they are, and the delays health seeking might lead to the, and their mortality from the other diseases such as malaria in some other area. And also health staffs are reluctant to see the patient with fever and cough, which is the similar symptoms with the COVID. A lot of stigmatization and discrimination to those who are with this symptom. So these are the kind of, how it affects it in terms of the general. And these are some of the pictures that, that were taken by our team. So as you can see, all the roads and, and everything is like blocked. So no one is allowed. They have written in different languages, in Naga language, in Kachin language, etc. So on the right side is our team, our field staff waiting outside the village, the blockage, and ask the volunteer to come out because he wants to provide the supply and also wants to collect the reports, so things like that. So they are not allowed to enter. And then I would like to explain, how we have done, how we have, tried to maintain the services. The most important thing is supply chain. Without the drugs and without the RET, then there's nothing that that the volunteers can do. So it's important that we provide a consistent supply chain, to avoid the stock out. So we are very, we are very lucky to have a very strong supply chain logistic and team in our office. So we took proactive action since the, even before the lockdowns and that the travel restrictions started in Myanmar. I think since in January or February, we did a assessment, and then we did a procurement, to make sure that we have 1 to 2 years stock at the central warehouse. And also we send all of, when we reach, and also we should be thankful to our donors and also some private donors who are very flexible. When we request, they are just give the approval within, within a week or within 5 days. And then we send the stocks to all our field offices of at least 6 months to 12 months, depending on how far. If they are far, we send more stocks, and if they are near, then we send 6 month stocks. And then from those offices also we send we make sure that we have enough supply to the volunteer side. So normally the volunteer side we supply only 3 to 6 months, but now we extend that like buffer stock up to 6 months, in some conflict area up to 12 months. And if we cannot go, we ask the volunteer to come out, and to come and get at the outside the village, or maybe to the cluster point for the resupply. And also we have to identify alternate transport cargo mechanism to send those, to make sure that the stocks arrive in time. And we also have to advocate local regional authorities. So in one office that we have signed, we have got the agreement that all the cars that include MEM supplies will be allowed. It's not, they don't allow the public buses for the passenger, but they allow our cars to because they bring the stocks for the community. So things like that. And coordination and advocacy is very important this time because like people have panic and different. So we have to make sure that we are on top of, we are there to, we are in regular contact, and we are there to help the township department and to help the community, to support them, when they need, whenever they need. So we maintain regular coordination and information sharing and advocacy to the local authorities and stakeholders at all levels. In the picture, you can see that our team with the district medical officer, we are supporting the posters in the local language and as well as the PPE. So logistics support is also one kind of support that we provided in this time, especially because the procurement system might be faster from as an NGO compared to the whole, government supply chain system. So, and also with this, we also get travel permit from the local regional authorities that, for what purpose and who is going from where, etc. And also we also supposed to in other activities like fever clinics. They open fever clinics, and so we have the medical doctors, we assist there, and also our volunteers are also assigned in the checkpoint for the fever screening. And these are some of the examples that I want to share. Some that you may not be able to read if you are not in Myanmar, but in this, the left side of the photo, that is like in one township that we work, that is COVID Response Surveillance Committee. So in the committee, you can see the top is the state health department, and then down there is a district health department, township department, and below there is like we have the MAM office and MAM feed team and volunteer. So this is how whenever we find unusual cases, one returning from other, or maybe COVID cases, some suspect cases with the COVID suspect symptom, then we inform along the chain in this committee so that we can support and we can be part of the team. And also on the right side there are two. These are the recommendation letters from the district health committee that this MAN team is visiting this A and B and C villages, for this purpose. They want to do mobile activity and clinics and malaria. So recommendations. So that's why we can get approval, and we have to submit the villages that the work plan, that which villages we are going to submit, and also the team members. So you can see our handsome young team members on the right side with the pictures, so we can see that. So this is how we get, how we coordinated and advocated with the health and administrative department to get access to the villages, to continue the services. And also this is also the photo on the right side is like a temporary quarantine. It's not quarantine, temporary shelter. Before they were sent to their townships, during this period, we have a lot of returnees, who came back from Thailand and China. So because this is the global pandemic, no one is prepared. So there are many, and then the buses are not ready. The quarantine facility at their respective townships, they are not ready. So they have to wait for maybe a week, at the gates, at the border gate points, while waiting that the facility, the bus is ready, for them to go back. So I mean, if you look at in here, that there's, if we don't provide, then I mean, if we don't provide the LLIN, then they will get infected with these are highly malaria endemic area, border area. So then our visitings at that time, the buses and all the transportation mechanisms are already stopped due to the travel restriction, as well as due to the public banning. So we are in the team, we are in the same township, so we mobilize our resources very quickly, and we supported our alliance to the township department so that these people are protected from malaria. So that is, how we have coordinated. And we have to do a lot of adjustment of the strategy. So it's like risk assessment. I would like to focus on the risk assessment in here, because as I explained in the first step, the risks, I mean, it's not like one strategy, one size fits all, because malaria is burden is very different in one township to the other. So which one, the COVID or malaria, what are we going to do? This township A will be very different from the elimination township, will be very different from what we need to do, in the very high burden township, such as in Palawa. So we have to do risk assessment, and we have to adjust the strategy accordingly, by township, by region. And then we have to follow the strict infection control procedure, That is also on why we want to protect the people from malaria. We also want to protect our volunteer and our staff safe from COVID. So we develop the infection control procedure, apply social distancing, we protect them by providing enough PPE. And then for all the clinic and for all these AT, and because our team open mobile clinics whenever they visit the village, we have to do interview appointment. We take that many people cannot come and wait there, so we have to pause them 5 people at a time, and the rest they go back home, come back in next 30 minutes, something like that. So we have to develop a triage system and door-to-door services. As mentioned in Shreehari and Louis, door-to-door services instead of mass gathering. And small group trainings and meetings instead of this big group. And we also have to explore the online meeting and training opportunity. to prevent the frequent contacts among each other. So these are some examples of how we set up. We developed the infection control procedure very clear, especially for the PHW. So we have to develop the infection control procedure instruction very clear because they have a limited literacy level. So it has to be simple, short, and like easy to understand. So which means that whenever you do the patient consultation, do outside, not inside of the home. Instead of doing inside, do outside at home, where there is enough ventilation. Ask everyone to wash your hand. Wash your hand every time whenever after you finish the testing of one patient, things like this. So have to be very clear and train them. And then we also ask them, okay, can you take the picture what you have done at your home and then send to us? So these are some of the picture from the right side are from our MEMV officers, and the picture from the left side are from the volunteers' home. So with the available resources, we have to make sure that they are applying or they are following the procedure. This is also some example from the volunteer training. We still manage to do volunteer training, and then we have plenty of space, so it's good for us, and we do the training using social distancing and using masks. And the next one, so the volunteers are also trained to use the mobile app. They are already using mobile phone, but now we train them how to use, in case of emergency, how to communicate. We created groups such as Viber group and like a Facebook group to report and not only for the routine malaria report but also for the in case of COVID associated issues like some COVID suspect cases or things like that. So that we train them how to use the mobile phone. This picture show how we continue to maintain the volunteer services in the community. So the first one is a village woman visiting the volunteer because she has fever, and then the second photo is it's not about malaria. I think it is our volunteer visiting a TB patient to do DOS, like to give instruction on to take the drugs regularly. And then on the picture, the big one on the left side is a small group health education to the community by our volunteer. LLIN, we do house to house, and as well as we also look for the opportunities where to provide LLIN distribution to the especially in the we pay more attention to the mobile migrant workers. So in the migrant work side, the volunteers, the pregnant women attended to the nearest facility, then we provide the LLIN at that time in this photo. MEMV teams are also conducting supervision visit to the village health worker, and in the picture you can see that on the right side this MEMV team is doing joint supervision visit with the government PHS in midwife. These are also, as I explained, in our feed team there is a medical doctor or a health assistant in nurse. So whenever they arrive the villages, they open mobile clinics so that they can provide the services, general health services. In addition to malaria, they can provide, other health services. Whenever they have fever or sick or other, they can come. So this photo showed our mobile team leaders doing mobile clinics and treating the community. And I think all the slides previously I presented are the general slide, but I also want to highlight, taking this opportunity, I want to highlight, what we did extra in the Palawa. As I explained in the very first slide, that malaria is very, different. Burden is very different. Palawa, 25% of the cases in 2019 came from Palawa. Transmission is very high, and also we started our operation in Palawa very late in 2016, in 2016. So the transmission is why the transmission is so high, because that the transmission, unlike in other areas, transmission happened within the village. that in other area in Myanmar, adult males are more high risk. If we look at the data in Palawa, like about 50% of the cases are under 5 children, like not under 5, like children who are normally stay within the village. They are not going to the forest. They are not going anywhere. So, which means the transmission is within the village. So, we have got to do something. So, we look at the data and we analyze. So, there are always 2 peaks, like very high transmission in June and also another transmission in October, November. 2 peaks, and in last year, there are, like in our program, there are 3 malaria deaths because of the delayed seeking. We don't want to happen. We want to prevent that. So, so we discuss with our team members in Palawa, and also then through them, we also explain to our volunteer. Look, in Palawa, because of the, there's a double burden. Malaria is very high. There's a conflict, like armed conflict between the Myanmar military and the local ethnic group. So because of the conflict, people are now incoming. Like actually, it's not like unlike in the border area, a lot of people are returning from outside country coming back. The COVID risk is very high. But in Palawa, like people are running and no one is like coming inside Palawa. So the risk of COVID is very low. And our field team, our MEM mobile team, and they are also not traveling anywhere. They are there, and they don't travel anywhere. The risk is they are not strangers. They are the local residents. So the risk is they are not. So you shouldn't be scared of them. Visiting your villages. So this is how we advocate, and then we explain that the COVID risk is very low, but malaria risk is very high. So we have got to do something before the rainy season comes. This March, April, May is the best time because the roads are good and we have to do something. So then finally we got approval and an agreement from the local village leaders and as well as from the malaria volunteers. So we did extras. What we did is here. So we started in April, which is in the middle of the COVID. We identified the hotspot. So out of over 200 villages that we selected the villages, 118 villages that has more than 5% positivity rate. And then we did door-to-door testing by volunteer and also as well as by MEM feeding. Using that, they definitely use the PPE, masks, and protection measures, etc. And unlike in we don't see much of reluctance or fear from the community by visiting our team, because as I explained, they don't see our team or they don't see the villager as a stranger. Because the COVID is, they are afraid of the stranger, but not to their community. So they are the community member, part of the community member, so they are okay to visit door to door. And they do the malaria testing, and also because we have the team leader, they also provide additional services. And then we started in April, and up to June 12, we finished the targeted screening in 57 villages. So we visit door to door and we ask, if you have fever, do you want to test? If you have malaria on the past month, past week history, do you want to test? So we offer everyone to do testing. So they are willing to come forward and testing. So in the 57 villages, the results are we have tested over 11,000 people with RDT. We found 99 positive cases because this is a low season, and because the low season, only 99 positive were found, and 73 were PF, mixed case, and 26 were PV. So out of that 73, 67 cases were asymptomatic, which means that they don't have the symptom. Otherwise, they might be, they will never come to the volunteer because they don't have fever. And then, 35 cases are children under 14 years old. So I think I'm on that side, on the right side, we show that on the map, you can see that the plan for our ECD and how many we finished and how many we plan to do and etc. So I'm very proud that we are able to do despite this COVID period. So in addition to malaria, then what are the additional activities that malaria volunteer contributed in the COVID? So they participated in the fever screening at the gates, assisting the township department, you can see in the picture. And also, as I explained, that like people have what you call fear and in around and incorrect information, a lot of discrimination and in panic. So it's a risk communication and engagement. Providing the correct information is very important. So our volunteers assisted the township department because they are the local, they can speak the local language. And here you can see that our volunteer putting the poster and also assisting the township department using the mobile speaker. So, and door-to-door communication. And also here, this is the EPI event, and our volunteer, as you in the middle with the black shirt and with the speaker, that is assisting township department to in the EPI event. So these are the things. These are the kind of additional activities that we participated. Some of the volunteers also help in the contact tracing for the COVID, things like that. So I will end my slide with a few lessons learned, shared from our experience. So I think daily, weekly is even late, it's a daily monitoring of the situation. If and the risk assessment is very important, not only for the COVID, but also with malaria, you have to identify which area, which disease has more risk, and tailor the situation accordingly, depending on the situation. And then proactive action needs to be taken, like procurement of the stocks, and you cannot send the stocks and the commodities only when all the transportation, are stopped. And also adjust the tailor strategy and advocacy coordination is very important. You have to engage with the local authorities and we have to be part of the team. And also the other one is like evidence-based information. Keep all the staffs and volunteers informed with timely evidence-based information. I would like to highlight the evidence-based information here because like many of the staffs and volunteers, they are panicked and they want to use, for example, one example is PPE. They want to use they use the whole gown and scrub suits and etc. But you have to follow the evidence. These are necessary only if you are handling with the positive cases. Otherwise it's not necessary, things like that. Because resources are very, very scarce. So you have to make smart decision. So then keep informed, but with the evidence base. And also to be able to inform, we have to create, we created an innovative communication channel, open channel using digital platform. So we create in the Facebook, we created workplace and with a group, and then we update every day. So all the feed teams has to update every day daily. On 9th of April, what happened in 17 teams on the 10th of April. So it's easy to follow and to check, whenever needed. And then emotional support and the reassurance of the safety is also important, Especially I will focus on the staff because if your staffs are not motivated, if they don't feel safe, and if they have all the fear and wrong information, then how are they going to support to the volunteers? So I think emotional support, stay strong and reassurance, and keep the open communication connected, that are very important. And protect the staffs, by provision of PPE. I think these are all the lessons learned from my side, and I would end this slide and I will hand over this to Lorina. Thank you.
Excellent. Thank you so much, Masu. I always learn so much every time you open your mouth, it seems. You've really highlighted so many of the challenges facing our community volunteers at the moment. And for those of you who have been following the Q&A chat box, apparently there has actually been one COVID case among community volunteers reported in Myanmar, which just highlights, the fact that they are at risk. And I really appreciate the fact that you highlighted the importance of us supporting our field team members, not just in terms of PPE, but also in terms of this emotional support and the importance of reassurance, and being so appreciative that we have these people in the field who are willing and able to provide these services. And some of the other takeaways I have from your presentation was how grateful we are that many of our donors are able to be flexible in enabling organizations like MAM to shift their response and to respond. And also how MAM has been able to really boost coordination with local authorities and that information sharing that has then enabled additional support. So it's great to see that this crisis seems to have just brought out so much great coordination and collaboration. I noted that being based in the community has been really important to enable this response. And I really liked the fact that you're doing these regular risk assessments and daily monitoring. And I think some of these lessons learned may actually form best practices that I think many of us can learn from as we respond. Again, this theme of trust between our community workers and the community members has been so important, and I'm sure that's contributed greatly to what MAM has been able to continue doing during this time. So thank you for that presentation, and congratulations for all the great work you've been able to do at this time. So moving along to our final speaker, Dr. Eisa from UNOPS will be taking a slightly bigger picture perspective and looking at CSO's contribution beyond malaria, but also into health system strengthening and the pandemic, and perhaps thinking about what we might learn going forward. So over to you, Dr. Eisa. Thank you.
Hi, Eisa. Then you have to open, okay, yeah.
Okay. Thank you, Lorina. Thanks to Masu, Louis, and Shri. Can you hear me, please?
Loud and clear, Eisa. Go ahead.
Good. It's a true pleasure really appearing here today in APMENxChange series. And I'm here also really honored and privileged to contribute to this important webinar. I'm going to start with refresher lines that are important if we are to understand my topic, which is to assess whether CSO is contributing to health system strengthening. And we have heard great examples of that already. I'm going to help you to walk through that by putting them in the appropriate box of the health system strengthening. How do we define health system? In today's complex world, it can really be difficult to say what exactly a health system means, what it consists of, where it begins and ends. The WHO defined the health system as a system consists of all organizations, people, actions whose primary intent is to promote, restore, or maintain health. Using the system framework, the WHO described 6 building blocks or essential functions for the health system. These include health service delivery, health workforce, information and data system, medical products, commodities, vaccine technologies, health financing, and leadership/stewardship. One thing that is so important is that these essential functions need to be strong if we are to achieve the overall goals of the health system, which were improved health, responsiveness, that is whether the system responds to changing health needs, as we have just heard the speakers, the last speaker, Dr. Masu, or change in the system itself. Goals of social and financial risk protection, improved efficiencies. These are all important goals. They are intermediate goals, which are access to services, coverage, quality, and safety. So these are very important if we are to work towards strengthening the system. When usually we look at the health sector governance and policy, people usually assess it against the public policy and how that policy supports the public health sector and vice versa. But the national health system is not limited to the public sector. In the past couple of decades, we have really seen an important shift, mainly due to the expansion of the private for-profit providers. We have seen also a proliferation of civil society, non-governmental organizations as charitable providers and community health workers. So although the public providers are usually referred to as the backbone of the healthcare system, in most health systems, providers actually constitute a complex mixture. So with this, the key point here is that in today's health system, we have a pluralistic system that acknowledges the importance of the public and the private sector, private for-profit or private for not-for-profit. Okay, from this, how do we place the civil society in the context of providing malaria services as contribution to health system strengthening? Is what they're doing at the disease control, is it really a system strengthening? Civil society, by their very nature, cut across actually those 6 building blocks of the health system that I mentioned. They do provide services. This is an important building blocks in any health system. They constitute a veritable low-cost labor for health service delivery, especially in remote areas, hard to reach places, forest areas in terms of malaria control and elimination. And where they are developed, and we have heard example of bigger organizations, they can easily plug the system into the existing national reporting system. They can be trained also to new technologies, all technologies and tools, for example, testing malaria or any other communicable diseases. And given their organizational capacity, CSO also can be relied on as a true partner in delivering malaria services, but other wide range of services, because they live within the beneficiaries of the health system. The fact is that civil society can even be tapped at the source of mobilizing resources. Masu talk about private donors, other than Global Fund, that finances and strengthen the health service and the health system. So if I listen at what presented by Sue and what was also summarized at the higher level by Louis, we could summarize the contribution of the civil society, the current civil society working in malaria in the region, in 5 types of contribution with widening scope, ranging from expanding the population coverage with health services and thus contributing to disease control, and also contributing to providing other package of health services, consequently leading to what we are aiming for in a health system is to achieve universal health coverage. Example of those health services were already mentioned. Second, supporting health workforce through direct hiring and deploying skilled health cadre and placing them in public sector, or also hiring, supporting, and supervising community health workers. Sharing knowledge, and Louis talked about mentoring, training, and de-skilling, which is to migrate delivery of services to less extensively qualified professionals, where the risk of transition is felt to be minimum. One example, for example, is substitution of nurses in places of medical doctors. Those field teams that work in some of the organization are qualified nurses who are trained to do a higher skill job. This is an important task shifting. Is strengthening health information system and disease surveillance. And we have heard about surveillance, the example from MAM in Myanmar contributing to the COVID surveillance. But actually, CSOs working in malaria are implementing malaria surveillance, such as case and foci investigation. And I would say CSOs are well positioned to provide also community COVID surveillance, screening fever, suspecting COVID while using protective measures would definitely help in the case identification. Contributing to health support system, supply and delivery of health products. And we have heard about door-to-door. We have heard about stocking of anti-malarials to avoid stock out in those remote areas. These are important support systems for health and important functions. Some of the CSO actually has infrastructures and capacities capable of doing COVID testing. These are key points that I take today and I summarize. So by looking at those activities today mentioned, we know that the work of the CSO is actually contributing to longer-term sustainability of the health system, strengthening it, adapting their work, while also achieving their immediate goal in terms of access, coverage, reaching population, eliminating diseases. I'm closing with a couple of challenges in addition to what Shiri has mentioned, Masu and Louis. But if we look at the bigger picture, CSOs still have the challenge. That means they need to continue to expand the community's participation in public policy. Stewardship is the most important in the health system function. Although the ultimate responsibility of the overall performance of a country health system lies with the government, the CSO are increasingly contributing to policy goal and thus also responsible for achieving that policy goal. CSO have to continue and they will face challenge in advocating for certain population group or disease, priority diseases, emerging diseases, requiring transparency, accountability for supporting those population or diseases. Although the CSO themselves may be restricted in activities such as providing specific services, for example, if they are not capable, they can't do COVID tests or other services. The key challenge is how CSOs support transition from external donor funding to more sustainable health system. We have had example already, and that will continue to be a challenge. We have had example of service integration, integrating malaria services with other diseases. We have heard the role of CSOs in surveillance, preventing re-emergence of diseases when we eliminate malaria. Knowledge transfer, de-skilling, these are all key activities to support transition. With this, I leave you here. Thank you very much.
Great, thank you so much, Dr. Eisa. There is a lot there. I think that was a really useful way to kind of lift up our thinking from what we've been seeing in terms of civil society responding to malaria and COVID, to think about what we can learn in terms of health system strengthening. And we clearly have a lot of great lessons. It's interesting to see how health systems really have evolved to become much more pluralistic now, and how both, well, all public, private and civil society all have something to offer, particularly in terms of knowledge sharing, potentially task shifting, our contributions to surveillance and different policy goals. And I like that you really called out that civil society do have a role to play in representing certain population groups, advocating for the prioritization of different diseases, and also in terms of disease integration and advocating for a shift towards more sustainability of health systems. So we definitely have a lot there. So thank you so much for your presentation, Dr. Eisa. And just to note, a couple of people have asked for Dr. Eisa's slides. We have got notes from his presentation that we will be sharing with the other presentations. So if you need if you'd like to think a bit more about his comments, they will be available to you. So I think we're ready to move over to our Q&A and our panel discussion. We've had a lot of great questions coming through from the audience, so thank you so much. A lot of them have been addressed directly in the Q&A box by the panelists. I think we may focus on some of the broader questions, and as I mentioned earlier, the panelists will be responding directly to any questions that we don't get to today, because we really do want to make sure that all questions are addressed. And no doubt some people might like more time to consider them, since there are some very challenging questions there as well. So I'm going to jump back to the top and ask a question to Shree. And something that I've been thinking about a lot these last few months is, you know, we always say that in every crisis there is an opportunity. And I think we've seen how civil society has been able to adapt as we move into, what is going to be a new normal. Things will probably be like this for the months ahead. What do you think we've learned as civil society that we can take forward not only into this new normal, but beyond that? How do you think we could build back even better? What are we learning now that could actually improve civil society's contribution to malaria and control and elimination going forward? And if I could add to that, thinking about what opportunities this creates for the CSO platform and cooperation between civil society. So Shree, I'd love to hear your thoughts.
Thank you, Lorina. That's a really good question, because that we have been picking this disease integration advocacy as an issue for the region, and this COVID-19 has highlighted the need for integrated service in the community. And lesson learned from this COVID crisis, it also teach us how to use available social media for communication and some of the information sharing, which we were trying to make that since we started, but there was a lot of challenges, but this COVID just pushed us for that. And now it's still at the local level, there are many challenges. There's the issue of network, Wi-Fi, everything, but at least people learn alternative option for the communication. That's a good thing. And just want to go back to disease integration services. I think moving forward, we should be looking how we can at least combine a few diseases that is realistic and practical at the community, and we teach our volunteer or malaria worker to respond those diseases. There will be a lot of questions to take this forward, but at least we can start thinking of community health issues, having some preparing volunteer with the basic understanding and knowledge of other diseases, not only malaria, because this we are talking about the whole this Grow Fund grant in this region, and this is somehow it's too much donor driven, and we are implementing malaria project, HIV project, and TB project maybe in the same area, but we are not necessarily talking to each other and integrating the service. So that, I think this was the very big lesson to us.
Great, thanks, Shree. Yeah, I like that. I love that we've had to engage with social media and technology in new ways that we can keep building on, and definitely seeing this, the importance of highlighting community priorities in terms of disease integration and so on. And that actually brings me to a question I have for Louis. We've been discussing a lot civil society's role in service delivery for malaria and COVID and now potentially disease integration as well. But I'd love to hear from you more about what civil society is doing in terms of advocacy, specifically around malaria elimination. And I'm also hoping that you can draw on some of your experience from other regions. I know we have a lot of participants from different countries with us at the moment. So perhaps some examples of what you're seeing in terms of advocacy from Africa and other parts of the world. Thanks, Louis. You're muted.
I think, can you hear me now? I think the work of civil society in advocacy is probably incredibly important. And that's because the ability to hold the system accountable for what it promises the people. And I think in this day and age where governments in many countries have failed to understand that they're there primarily to serve their populations, they are the servants of the people. One of the things that civil society does through its advocacy is to ensure that that remains front and center, that we are providing services that are focused on delivery based on on human rights and based on being gender sensitive and being based on community needs. And so a lot of the work in terms of advocacy that the platform has been involved with is around accountability and transparency, but also this idea of resource mobilization. We in the next 3 years, it's likely that the Global Fund will not carry on funding the malaria elimination program in the Mekong at the level that it has. And therefore we need to move over to increasing funding from the countries themselves. And you know, the Global Fund has this very interesting project in Myanmar with UMFCCI, working very much with private providers and the private sector. So, you know, advocacy in terms of helping countries understand their role and responsibility to provide services to their country, their role and responsibility to ensure sufficient resources going forward, and then their role in ensuring that countries implement the right policies and actually implement them. And then finally, for the Mekong area, but also across Africa, this need to ensure that all populations are served. Within the Global Fund and within the global community, there's this mantra of leave no one behind. And yet our systems leave many, many, many people behind. And if you're poor and you are in a remote area and you're a migrant, you're one of the HIV key populations, you are a prisoner, you are one of the populations impacted by TB, then actually you are left behind. And one of the roles that we have is to ensure that we keep governments and we keep the international donors and the international organizations true to their word, that we are truly not leaving anyone behind. So that's another really important part of the work of advocacy. And then I'd say finally ensuring that we are truly delivering services in a way that is useful and relevant to the community. So it's moving from a top-down approach to very much a community-based approach. And I think one of the things that we've learned with COVID is the need to bring services as close to the community as possible. Trying to operate stuff out of capitals, particularly with this, problems with travel restrictions because of COVID, has made us think, like, how do we bring services as close to the community, and how do we make those services as integrated as possible, so we're not just working in a vertical program. And so part of our advocacy around transition and sustainability has to be, how do we work more effectively with other disease groups? And so specifically for the CSO platform, I would like to see the platform move to being a CSO platform for health and nutrition, because there are several areas where the social determinants of health need to be adequately funded to ensure that we are having healthy communities, because healthy people, healthy communities lead to healthy economies. And you can't differentiate between having focus on a healthy economy and a healthy financial system without really truly focusing on a healthy health system. And healthy health systems start with community system strengthening, because it's at the community.
Beautiful, Louis. Thank you. I love that you both laid out the challenges and the enormity of the situation, but I'm kind of left with a feeling of hope that actually we really have learned something at this time, and we do. And even though this crisis has really exposed so many of the weaknesses and gaps that our health systems have, it's also created a way forward in how both civil society can really focus its efforts in what it needs to be advocating for, how it can engage, and the importance of, as you say, of this community-based approach and keeping close to the community to best represent their needs and their priorities. Yeah, a lot of great thoughts here. It's really
Lorina, just one more thing. I think as long as we focus on social justice and equity in terms of our health delivery, and really focus on the people most in need, then we will have a health system that is fit for purpose. And I think the huge inequities have been brought to the forefront as a result of COVID. So hopefully we will focus on those things that really truly matter to ensure that communities access the services that they need in a way that they need it.
I love that. And, you know, I think it's a conversation that we don't often have, or we don't have enough in the malaria community. Often we're so focused on service delivery and surveillance and all the technical aspects that we don't think about, why is this still a problem? There are no rich people dying of malaria that I'm aware of. Malaria remains very much a social justice issue. And I think it's a really helpful way to think about this and how it needs to take it. We need to take it forward. So thanks for raising that, Louis. It's really a refreshing conversation. But I would like to turn also to Ma Su, who I think Ma'am has given such a great example of turning crisis into an opportunity and how civil society is still able to respond. And I'd really appreciate your reflections on how you see Myanmar, I think, is ahead of the curve in terms of integrating diseases for its community health workers. But I'd love to hear more about how you see we could repurpose community health volunteers to either respond to outbreaks or more of these community demanded needs that Louis was suggesting. And I'd also like to throw in, excuse me, a question that is related to that came from the audience around the risk perception of volunteers and how perhaps community members are seeing the risk of the volunteers and how we can respond to that at this time. So over to you, Ma Su.
Okay, thank you, Lorina. Thank you, the audience, for asking the question. So let me start with the risk perception. You know, I mean, it could be different for different country perspective, you know, different partners, you know, because I'm representing, you know, the MEM volunteers. As we all see in the map that, you know, we work in a very remote area. So in those remote areas, and the population mobility is already limited, you know, so they don't like in Naga, which is very like not eastern part of Myanmar. So people don't move around, you know, that much. So which means that, you know, that the perception to the risk perception, I mean, there is a risk perception, they heard about it, but the risk is associated with the, you know, strangers, you know, that is, you know, that is how we learn from them. So the risk is for those who are from other townships, who came back from Yangon, or who came back from, you know, from outside the country. You know, if you are living in the same community, you know this person, they don't go anywhere. They go to the farm and they do farming and they do, you know, planting, and they came back. So for those that they don't see that risk, so that is okay. So that is how we, you know, okay. So for that, you know, our team, you know, like for example, we need to go there, you know, to support the volunteer, you know, to stay connected with the volunteer. So we requested, or like we encourage our team member, like to not to travel, I mean, to stay within the same community with them. So in the same township, as long as in the same villages, they are okay. So that's why, like, they are, we don't, you know, that might be different from for other partners, you know, for other country that, you know, the transmission is so high, the whole country, you know, if the transmission is everywhere, the scenario might be different. That's why I mentioned in my slide that we need to do risk assessment and regular communication. You know, what is the perception? Has the transmission has changed? Has the community perception has changed? What do we need to do? You know, things like that. So we need to do regular assessment. So if you are living in a, like a, you know, Myanmar Thailand border, like in Myawaddy, or maybe in the Loeche, where you have the returnees every day, like 1,000 running, that might be different. So for us, is, you know, the risk perception is that we just have to explain them that, you know, this is transmission is low, and the transmission is not a local transmission yet. So that is, you know, so that is our experience. So, and also on the other hand, we also like explain them, you know, in a language that they can easily understand. So like maybe specific example might be that the virus, I mean, I'm explaining the language that we use for the volunteer. The virus doesn't have the feet, you know, like us. They cannot walk and, you know, like go and crawl over you to you, which means that the virus is like immobile. They cannot move. Only if that somebody cough or, you know, like a sneeze, that can transmit along the cough and then reach to you. So, which means that if you keep apart from someone sick person, if you wear the mask, if you ask that person who come to you with a cough, ask that person to wash the hand at the front of your house, and also ask that person to put the mask, you are safe. That is, and after you finish like treating, testing, then you wash your hand. I think that is how a very simple language that we use to train our volunteer to continue the services. So I think it will be like, depending on the context, depending on the what you call risk perception faced by your volunteer. That is. The second question is about integration, right? I think I'm glad that you raised this question. I think I'm very excited, and I think this is an opportunity. Because I mean during this period, the role of volunteer has has been even seen more than ever. Because like previously they are just like sitting and doing like testing only. Now they are helping for contact tracing or helping for the screening at the gates, and also doing in door to door. So their role has been recognized, more than ever. And also they are also, I think, motivated, like for example, you have to explain that like, this cannot be transmitted easily. But after that, they are happy and to help the community that that they live in, they are motivated, and they are seen as they receive the recognition. So I think this is a good time to advocate for the integration. For the integration, definitely can do that because the number malaria is declining, the number of cases is very low, only about like 20, like average is like only about 10 or 15 testing per volunteer per month, like 10, which means that like one testing in like 2 days. That's like, if you don't expand their role, they will become demotivated, they will be bored, or maybe at the end, they might see that, okay, it's not important, we don't have to do it anymore. So I think if by adding them the role, expanding, like, okay, you can do more, you can do screening for the like COVID. Whenever you find cases, then you have to create a mechanism. They need to know who to communicate, who to contact whenever they find cases like surveillance. So when I say surveillance, it's not only COVID, it can be anything. Whenever like measles outbreak, they are the first person, they will notice the case, something unusual happened in the community. It can be dengue, or like something, anything. So if they are now, this time, they are officially connected with the township department, so they can be part of the surveillance system. So this is not only the surveillance system, they can be, I think all the disease procedures are the same, like for dengue preparation, community engagement, for COVID, everything is very similar. So the caseload is that the workload is also very manageable for them. So I think integration, this is a good time to advocate for the integration, It's very excited. So thank you for asking the question. Yeah.
I love it. Turning a crisis into an opportunity. Thanks so much, Masu. While you were speaking, there has been a bit of side conversation happening with the panelists. And I think that so many of us have been so inspired by what MAM has been able to do that I'd be interested to hear from our participants as well, whether it might be worth developing your experience into a case study and pulling out some of these best practices that we can share across other civil society organizations, just to show how adaptation is possible, and perhaps to try to really pull together some support to advocate for more integration, as you say. It's really exciting to hear that, during a crisis, the community is able to pull together, and that our volunteers have really been recognized as important to this. And I'm so glad that our volunteers have been feeling motivated as well. I think in the face of a crisis, when people are actually able to do something in order to respond, it's very empowering. So thank you so much for those comments, Masu. I'm going to kind of move from there back to Dr. Eisa. So Masu was saying that this is a great opportunity to advocate for more integration and a stronger role for community health workers. And from your expert opinion as a health system specialist, do you feel that the current pandemic has accelerated civil society's ability to contribute to health system strengthening, or has it threatened it? Could you share us a bit about how you're seeing what civil society could do from here in order to contribute more effectively to health system strengthening?
Thank you, Lorina. I think that the example from MAM is really crystal clear how CSO are ready to move even when the pandemic hit in a way that we're not prepared for it. And we are lucky that Myanmar has not seen those scenarios that WHO has projected, but the civil society in Myanmar, and we are working with 50 of them across the Mekong. We have seen great example actually how civil society continued to engage in delivering what they are delivering, but also repurposing some of this, their staff, their activities to respond and to support the national effort in responding to COVID. Let me just go back quickly. One of the things that we have seen as a principal recipient, that the civil society with the national program, with technical partners like WHO, while responding to the crisis, while ensuring the safety and the protection of their staff, their volunteers, they have worked on risk assessment in a systematic way and developing contingency planning to ensure the continuation of implementation of those activities. An example, for example, from civil society in Cambodia. Civil society in Cambodia have developed a contingency plan that categorized their activities into 3 categories. Low risk activities. Those activities they recommended they could conduct, they would continue to do them using appropriate personal protective measures, something like testing. People coming with malaria, they know that with fever, it could be malaria, it could be COVID, but they still, with the appropriate protective measure, they continue to do testing. We have seen the number decline, but later on picked up when they have the protective measure. They continue to do treatment for malaria. They have continued those vector control, where we have seen they conducted mass campaign of distribution bed to bed. So this is an example of a low risk activity that does not include, for example, mass gathering. Other categories, they categorize as medium risk. Those one, they recommended they could continue delivering them while the epidemic's going using digital approach. For example, subnational malaria meetings to ensure that there is data verification, there is feedback, there is continuous training. Those could be done through digital approach, and we have seen actually even in UNOPS, we have revised our business processes to capture those meetings documented through digital means, participants taking a screenshot of a training of a meeting. There are some high risk activities that they recommended to postpone. For example, mass gathering, World Malaria Day. It coincided, 25th of April when we were in the lockdown. Larger workshop, community mobilization. Those activities were postponed. And as the situation improved, they will go back to them. So this risk assessment, this contingency planning, it is really something that we have seen from several civil society in the region. The example from Cambodia stands very, very good. Okay, let's move to civil society adaptation. From day one, civil society joined in fever screening. We have seen ARC, the American Refugee Committee, supporting the national program along the Myanmar-Thai border, doing fever screening for the returnees, distribution of PPE, distribution of personal hygiene, soaps, hand sanitizer, gels. But we have seen the CSO contributing to even higher system strengthening, delivery of supplies, delivery of anti-malarial to those communities, delivery of PPE equipment. We have sheets and tallies of how much being delivered by which CSO. And I have a list of 14 CSOs here who have repurposed their work in the field to support the COVID response. We have seen SMRU in the Thai-Myanmar border actually supporting the COVID testing. So an organization like SMRU have capabilities of laboratories that with the Ministry of Public Health registration and approval, they are conducting COVID testing and supporting also the surveillance and the response. I will stop here. I can go on and on.
Thanks, Eisa. I'm sure many people would be very happy for you to go on and on as well. Yeah, as you say, there are a lot of opportunities and a lot of lessons learned that I think we can definitely take forward, and especially in terms of this, of risk assessments and really categorizing activities and building greater coordination around that. I'm actually going to jump back to Louis because I know he's busting to share some thoughts on this as well. So go ahead, Louis.
Hi there. So, I think we have a real need to focus on policy. And I think CSOs would be so much more effective and are effective in countries where there's close collaboration with government, where there's genuine integration. And so, you have within the Mekong, you have five countries. You have a situation in Myanmar where disease integration is allowed and is taking place and is moving forward, to countries like Thailand and Vietnam, where civil society and community people aren't even allowed to do testing. And so, how do you actually ensure effectiveness in terms of malaria elimination when the people involved aren't able to travel, when people are frightened to come to health centers? If you don't have that, I think COVID has taught us that if you don't have effective service delivery at the community level with people that communities trust, then I think the work that MAM is doing is simply outstanding, because they're actually in these remote communities. They're in places where most governments and government people find it very difficult to get to. And so how do we use policy and policy change to really move forward with malaria elimination? And without integration, we are simply not going to be able to eliminate this disease. When you have very few cases, as you do in Thailand and Vietnam, it almost becomes a forgotten disease. And so something like COVID can completely swamp you. Whereas we actually ought to be using COVID as a way to show governments that without changing their policies, without better integration, without stronger community engagement, without actually putting communities front and center and not as a last resort, not a top-down. I think so many things that we've learned in the last 2 months that we need to apply more widely to be able to ensure that we are actually working effectively, particularly in an area where the competition for resources is intense. And as your disease becomes more and more invisible, it becomes more and more difficult to focus on that just one disease. And so having an integrated platform and having communities provide a number of different services at the same time when they're actually there on a door-to-door basis, for instance, is a critical way forward. And we need to find ways to change the policy to allow that to take place effectively.
Great. Yeah, thanks, Louis. I couldn't agree with you more. And again, I think these are issues that that often get sidelined because everyone is often focused on the service delivery side. And I think that all our speakers today have just really highlighted that this is a unique opportunity, that we really have been able to demonstrate something different in response to this crisis. And this has to be the time that we take this to the policy level and respond. Before we go over to some of the audience questions, I'm wondering if any of the other panelists would like to respond to anything that Louis said. 3, 2, 1. Silence is no. Everyone agrees.
No,
well
it's
done,
not on Louis, but I just would like
go
to
ahead.
touch on what Dr. Eisa said. He said one of the good learning from this COVID crisis. Dr. Eisa mentioned that CSO, they repurpose their activities, but at the same time, donor also was very flexible to reallocate money from the malaria grant to respond COVID. So that was also a really great example. We saw, and I think we should be learning moving forward. And also to Louis' point, he mentioned about bringing services as close as to the community. that also, and then providing support to the community people. Some of the CSOs, they mentioned that this COVID teach them more in prevention is really better than going to the cure, which we have been struggling to change people's behavior, especially in malaria. In this region, unlike in Africa, people, they don't take malaria as a killer disease. And it's been very challenging to change their behavior. But COVID suddenly come in and then it teaches that prevention is better and we can do it.
Great. Yeah, thanks, Shrey. That's a really, really useful addition. Although at the moment I find myself slightly distracted by the pink dot on your shoulder. What is that for?
This is COVID screening.
Ah, well done. Well done. Great. We have a few minutes left, and I'd love to turn to the most upvoted question in our Q&A box. So excuse me while I read. This question comes from Baso Tet, who is a regional malaria officer in Eastern Shan state of Myanmar. So during COVID-19 period, although there is travel restriction within the area, the CSOs and village health volunteers could perform case finding and treatment activities, as we have at least one volunteer for almost all the villages. However, specifically, we have to perform special activities like case investigation, foci investigation, and response by respective health staff with technical support. And in fact, it is not possible at the moment. So in your opinion, how would you proceed in that specific situation? Do we have any volunteers from our panelists to address this question?
Hi, Lorina. Yeah. Okay.
I thought you might jump in, Masu. Go ahead.
Yeah, because I mean we are from the same country. So I think I am not I'm a generalist. I'm not a malaria specialist, but I would respond in a general that you have to do like a risk assessment and what can be done. What is the essential critical activities and what can be what can wait or how to do differently. So in this case for elimination, I think we have to find a way, how to do it. For example, if that, this area is only like 1 or 2 cases, and do we really want to do, if the volunteer cannot, if there is area, if this area is like, for example, high transmission, of the high local transmission of COVID, and then malaria is very low, only 1 case, then do we really want the volunteer to come and to travel and do that? And then the other question is that, if we really want to do that, if we are like, afraid of, malaria outbreak, rebound, like elimination, but it's like coming rebound. If we are worried that there are recommendations, from the Global Fund and from the WHO that, I think we have to make sure that enough stock is there, This time is saving lives. It's not about the surveillance, right? So in my opinion, for example, if we are worried of this like outbreak, like a rebound after elimination, then we have to make sure that enough stock is there. We have enough RDT provided, we have enough HDT provided, and then if we suspect, then we train like clear instruction to the volunteer and maybe to someone else, to do within who live in the same community or maybe same township. People who in the same township can always travel. That is my experience. So you have to instruct someone from the township department, to travel and then do testing and also treat who are positive and save life, and then record. But we might not be able to do, case investigation, foci investigation, which can be done later. But saving life is very important at this context. So that's why we, my maybe suggestion, but some people may not agree. I'm not a malaria expert, so yeah. Okay. Yeah.
Lorina, can I say something?
Go ahead, Louis.
So we had the privilege with the CSO platform to actually do a field visit to Myanmar from Mandalay, and PSI at the time were actually trying to carry out foci investigations and case investigations. And I think we made the point then that trying to bring these activities as close to the community as possible. There were some amazing local workers that PSI had that would be perfectly capable of carrying out the work of case investigation when you have an indigenous case, to see who else within the vicinity has been affected or has the disease and stuff, being able to do the testing. And I think that COVID has focused us on the need to actually do that as close to the community as possible. And therefore we should increase and spend our time and our resources on empowering the people as close to the community to be able to carry out these essential functions. I think that, you know, we see community health workers, mobile malaria workers, and staff, field staff in these remote communities as just providing us information and uploading their data for surveillance to the national program. But actually, I think they are ultimately the users, and they need to be engaged and involved in not only producing that information, but using that information and using that information to supply, you know, accurate messages to their communities, because they're the people that are actually trusted. And so that, to me, this is absolutely a case of focus our work on ensuring that we have people as close to the community to be able to carry out these functions.
Q&A on. We're rapidly running out of time, and I know everyone has already dedicated a lot of time to this webinar, so I don't want to keep us any longer. Optimistic about what we are able to continue doing right now. I feel that what the changes that have been made, the relationships that have been strengthened between civil society and community workers with the community, as well as the engagement that we're seeing with local and national authorities to really work together to respond, the flexibility of the donor community. I think this really sets us up well to look beyond the pandemic towards malaria elimination, towards health integration, and towards health system strengthening. So there is a lot here, a lot to learn, and abruptly, but I would really like to thank, first of all, our 4 panelists for putting so much thought and preparation into your presentations today. I think everyone's really enjoyed them and gotten a lot out of them. So thank you so much for sharing your experiences and perspectives with us. I'd also like to thank the APMEN team. Amita, this is such a wonderful initiative when there's so much going on, just to take time to reflect and to share. It's really useful, and I'm sure people have appreciated being able to come together for this. Chris, Sai, Tin, Pom, behind the scenes, we could not have pulled this together without you. So thank you so much for your great support for this webinar and inviting me to participate. I've really enjoyed it. You can see on your screen there are some follow-up, there are some contact details where you can follow up and learn more. We will be sending out the presentations, the recording, answers to the unanswered questions. And would also like to ask you to please stay on the line when this webinar ends, as we have some poll questions that we're going to launch to get some feedback. In fact, you can probably even see it now, so we'd really appreciate your feedback. Thank you all so much for participating, for your time during these very busy days. I hope you've enjoyed the webinar, and I hope that this conversation continues. So thank you all so much, and have a great day and stay safe. Bye.
Thank you, Lorina.